everybody. Today's topic is Can India End TB by 2025? To justify the topic, we are privileged to honor Padma Shri Professor Dr. Digambar Behera. He requires no introduction. Professor Behera is an undergraduate alumni of SC Medical College, Cuttack. Recently, he retired as senior professor and head of the Department of Pulmonary Medicine, Postgraduate Institute of Medicine, PGMR, Chandigarh. He served as a Dean Research, PGI Chandigarh. Professor Behera was director of LRS New Delhi for a long time. So during his tenure, he has improvised. There is a lot of changes in the LRS TB Institute. I am privileged to work under his chairmanship of National Task Force, NTCP, and National Technical Expert Group, the Ministry of Health and Government of India. He remained as a chairman in various clinical trials of ICMR. One of the trial is the TB vaccine, which is also going on in our SCB Medical College Department of Pulmonary Medicine. Presently, he is the president of Indian Society for Studies of Lung Cancer and Indian Chest Society. He is a renowned researcher in the field of respiratory disease and tuberculosis. I will not take any time. Everybody is interested to hear from Professor Padma Shri Professor Behera. Sir, I invite you for your talk on this field.
Thank you, Professor Patnaik. Respected Professor Hota, Dr. Gita, then the senior faculty members of the SCB Medical College, and then my fellow SCBians. It is my proud privilege to speak before you a topic which is close to my heart. Now, if I can share the screen, okay. Okay, can. Is it visible?
Yes, sir. Yes, sir.
Yeah, thank you. So, you know, I think I was asked by Professor Patnaik to speak about can India end TB by 2025. Yes, I'll try to take you through the journey of a TB control program of India over the years. It is almost now, I know we started in 1993 when the revised national TB control program started. Now it is almost nearly 30 years. So we'll see how we are and whether we are able or will be able to end TB by 2025. So what I like to discuss with you is I'll just give you a broad overview about the burden of TB and what is Ntv strategy and what the program is doing, and then the various advancements that has taken place in the field of diagnostics, the treatment, and the other aspects. And then obviously I'll end my talk whether all these achievements will be able to take us to end TB by 2025. You know, as you know, TB is one of the world's top health challenges. More than 2.4 billion people, which is equal to 1/3 of the world population, are infected with TB. You know, we are all infected, about 1/3 of the people. And then each year, about 9.6 million TB cases, they occur in the world, and out of this, about 1.5 million people die. This is what is the global scenario. And again, it is one of the top 10 causes of death and the leading cause from a single infectious agent, you know, that above HIV and AIDS. And as I have already told you, a total of 1.4 to 1.5 million people died from TB in the year 2019. And in the same year, an estimated 10 million people fell ill with TB. And of that, about 5.6 million were male, 3.2 million were women, and 1.2 million were children. The TB is present in all countries and all age groups, but the positive point is TB is curable and preventable. You see, this is a busy slide, but this shows the global prevalence for 3 different years, 1990, 2007, and 2017. Although I am sure you will not be able to see this slide very clearly, but what it says in the year 2000, in 1990, the tuberculosis was the 4th common cause of burden of diseases. The same to maintain in 2007, and it still continues to be the same in the year 2017. Although there is a slight change in percentage wise about the burden, about the contribution towards death, etc. You see, we have got the global tuberculosis report. It comes every year, and the latest report we have got is for the year 2020, and the 2021 report will be coming sometimes around October. But the latest report is that of 2020. You know, as per that report, this gives an estimates of the TB burden for the year 2019. So this is the global scenario, and this side is what is happening in India. You see, as I have told you, in the year 2019, we have got about 100 lakhs or the 10 million new cases of TB in that year. And in India, the figure was around 26.4 lakhs or 2.64 million cases. And with about 193 cases per lakh of our population. And you see about 26% of the global burden of TB is in India. Similarly, about 1.4 million people died in the year 2019 because of TB. And in India, the death was about 4.45 lakh. That is the death, that is about 33 per lakh our population. And again, if you see, about 1/3 or 32% of the total global death was in India because of TB. Then another important area is the multi-drug resistant TB that we'll discuss little in length subsequently. You see, in the year 2019, there were about 4.65 estimated cases of 4.65 lakhs estimated case of MDR TB were there. And then in India, the figure is about 1.24 lakhs, and that is coming about 9.1 per lakh population. And again, if you see, nearly 1/3 of all MDR TB cases in the world are in India. So you can see when it is the overall TB cases, whether it is mortality, whether it is MDR TB. So almost a large chunk or India is the highest number or is having the highest number of such cases in the world. Then again, I think I have told you the same thing already in the previous slide. Again, another interesting thing you can see, both the TB, HIV, and multi-drug resistant TB. So there is a overlap always because the three are very close associates, as you all know. So then there is a overlap, and you can see there are certain countries, about 10 countries out of the 30 TB high burden countries, both TB, MDR TB, and TB HIV. Then these few 8 or 10 countries, and India is having again a conglomeration of TB, MDR TB, and TB HIV at the basis of the absolute number of incident cases. The same thing as I was telling you, as per the global TB report 2010-20, India has about 26% of the cases. That is the highest number of cases of the world TB is in India, and a 2/3 of the entire global burden is in 8 countries. You can see in the other countries like Indonesia, China, Bangladesh, Pakistan, South Africa, Nigeria, and the Philippines. And then in addition to these 8 countries plus another 22 countries, that is about 30 countries, they account for about 87% of the total TB in the world. You know, the tragic mathematics, if you say the people, how many people die because of TB, if I can give a comparison between the global and India, you see I told you the 1.4 million deaths per year. In India, it is about 4.45 lakh cases. So per day, it is coming about 3,800 in the world. And in India, about 1,219 people die per day because of TB. And that is coming to about 51 cases, deaths due to TB per hour, and about 0.85 deaths per minute in India. I think that is what is the enormity of the problem of tuberculosis in our country and also in the globe. Now, because of this problem, then the TB control was given one of the priorities or one of the important areas of government of India since the soon after the our independence. You see, in the 1950s and 60s, the important TB research that occurred at that time in the TB Research Center, TRC, Chennai, now known as the NIRT at Chennai, and NTA National TB Institute at Bangalore. And in 62, in fact, we had a national TB program that was called as NTP, but it was not a structured program. It was just known as a program. And then in 1992, the program was reviewed, and then many shortcomings were recognized. And then, because at that time, why it was reviewed? Because under that previous national TB program, only 30% of the patients could be diagnosed. And of these, only 30% were treated successfully. Meaning thereby, if there are 100 cases of TB, so only 30% will be diagnosed, means 30 could be diagnosed. And out of these 30, only 30% were treated successfully. That means 9 cases. Out of, you can see 100 cases of TB, only we are curing 9 patients according to that national TB program. So therefore, in the year 1992, the review started, and then the name was changed to RNTCP, a revised National TB Control Program. So the next year, the piloting was started, and then subsequently over the years, the RNTCP was scaled up. And by March 31st, 2006, the entire country was covered under the program. With the goals of our RNTCP was, the goal of the TB control program was to decrease the mortality and morbidity due to TB and cut the transmission of infections until TB ceases to be a major public health problem in India. And the objective was what we call as the 70-85 strategy. That means to achieve and maintain a cure rate of at least 85% among the new sputum positive TB patients, and then to achieve and maintain a case detection of at least 70% of such cases of the estimated incidence. So this is what we call as the 70-85 or 85-70 strategy that was there. With that, the RNTCP started in the year 1993. And then over the years, the much water has flown, and then this is the evolution. The initial part, as I have already told you, we had the National TB Control Program, then the RNTCP, then in 1997 introduction of RNTCP and so on, and then the other parts were how the planning was started, then the pilot, then the drug-resistant TB that we'll be discussing little later subsequently, and then the basic principle of that was the directly observed treatment short course, or what we call as the DOTS. There are the 5 important components. That was the political commitment, the diagnosis by microscopy, and adequate supply of the short course chemotherapy drugs. And then the treatment was directly observed, and then accountability, or what by maintaining of the register or giving an accountability of that. So that was the basis of our DOTS, the 5 components of the DOTS. Then, of course, with that, the global TB strategy also changed. So when with this into the 1994, as I told you, we have got the DOT strategy with those 5 strategies that established a monitoring system. Then in 2006, the strategy was what was called as the Stop TB strategy, to pursue the high quality DOTS expansion and enhancement and addressing TB, HIV, MDR TB and other challenges. Then contribute to the health system, engage all care providers, empower people with TB and communities, and enable and promote research. And of course, again, it was reviewed in 2014, and then the Stop TB strategy was changed into End TB strategy. It was integrated patient-centered TB care and prevention with bold policies and supportive systems, and with, of course, intensified research and innovation. That is how this is the evolution of our global TB strategy. And I think India is also going through these strategies and adopting those things. You see, now we have the Stop TB strategy that I was telling you in 2006. So that was WHO launched this Stop TB strategy to reduce dramatically the global burden of TB by 2015 in line with the Millennium Development Goals. You know, that is the MDG of the United Nations and the WHO, and to achieve universal high quality diagnosis and treatment. And then the target was to, by 2005, to detect that same thing I was telling, the 70-85 strategy. And by 2015, to reduce the TB prevalence and death rates by 50% in comparison to that of the figures in 1990. So this was comparison between 90 and 2015. And then at that time, the target was by 2050, the eliminating TB as a public health problem, meaning thereby to having less than one case of TB per million population. So that was what the Stop TB strategy. And that was the aim at that time from 2006 to 2015. So however, there was again, this was revised in 2014. That is what is the new strategy. So WHO proposed a resolution in May 2014, what we call the new post 2015 global TB strategy with the ambitious targets, you know. So this is, so moving from the halting TB, which was there till 2015. So now it was to end TB by 2030. So this is the Sustainable Development Goal target 3.3 by 2030 to end the TB epidemic. That is what we call as the end TB. So from the MDG era, that is the Millennium Development Goal era. So the strategy was to go into the Sustainable Development Goal era from MDG to SDG era. So the strategy here was from stopping TB to ending TB and ultimately eliminating it, translating quest for equity and social justice, universal health care and social protection, to access to high quality service, placing at the center all people vulnerable to or affected by TB, rapid introduction of innovation such as new tools, policies and systems, and all of the society approach, not just all of government. It was not only a government, but it was a societal or social movement. And in the end, acceleration of the incidence and mortality that should be declined. So we have now moved towards the new era of Sustainable Development Goal, and from Stop TB strategy to End TB strategy. So that is how the strategy went. You know, what is this End TB strategy? You know, the vision here is a world free of TB with zero deaths, disease and suffering due to tuberculosis. And the goal is obviously to end the global tuberculosis epidemic. So what are the indicators? Here, the reducing the number of TB deaths compared with that of 2015. Here, 2015 now is taken as a baseline. So the milestones by 2020, it should be reduction should be by 35% in comparison to what was in 2015. And by 2025, it is by 75%. And the target was that by the year 2030, it should be reduction should be by 90%. And by 2035 by 95%. Similarly, the TB incidence rate in compared to 2015, the reduction should be 20%, by 2025 by 50%, and by 2030 it should be 80%, and by end of 2035 it will be 90%. That means it should be less than 10 per 100,000 population. And the third indicator was that TB affected families facing catastrophic cost due to TB should be zero. That means no family should bear the financial crunch because of TB directly or indirectly. That means it should be the responsibility of the government as well as the society to take care of that part. So this is the Ntv strategy, and these are the various indicators. And then there are certain principles. I'm not going to that. Here the government stewardship and accountability, monitoring and evolution. There should be a strong coalition with the civil society, the organizations and communities, protection and promotion of human rights, ethics and equity, adoption of the strategy, and then there are certain pillars, then bold policies. So with that, you see the same thing. There are 3 pillars, and these are the milestones I have already told you by what year it is to be done. You see, to break this trajectory, what happens, you see what I call a current global trend. You see, we are reducing the incidence of TB by about 1.5% per year. So with this rate, obviously we cannot reach the target by 2035. But however, this curve, this straight line should be pushed backwards that way. Say, for example, by optimizing the use of current and new tools emerging from pipeline, pursue universal health coverage and social protection. If we can reduce this, the trend of reduction can be minus 10% per year by 2025. So then, and then again, by introducing new tools, vaccines, new drugs, treatment regimens, etc. So if that can be reduced by 5% per year, so overall, if we do that, then the reduction will be only 5%, even with this. But actually, to reach the target of 2035, actually the reduction should be 17% per year. You see, this is a huge task. This is a mathematical model. You can see this curve, it has to be pushed still further, and accordingly, our strategy should be there. But again, another interesting thing happened. Our Honorable Prime Minister in the Delhi Ntv Summit on 13th March 2018, what was that? Was innovation and action to end TB. So what that was a landmark event towards complete elimination of TB from the country. So Honorable Prime Minister Sri Narendra Modi ji announced the targets for ending TB by 2025. You know, much ahead of the global SDG targets of 2030. That means he directed and he suggested and he instructed that our Ntv strategy should be advanced by 5 years. So he emphasized the importance of working together for the cause as the disease is aimed to the betterment of the lives of the poor. So that was what was the directive, and that is how the Ntv strategy in India, actually the year is 2025. So that is what Dr. Patnaik had asked me to talk, and that is what we'll see. So can we do that? So now before coming to that, let us examine what the program has achieved or is doing. What are the various achievements? And so there I'll just try to give you an update of the RNTCP. So the India TB program is caring for 1.5 million TB cases in 2016. And again, this we have to now care for about 3.5 million cases. Now, if I summarize for you, what are the achievements since the inception of RNTCP in this country? When by March 2006, as I told you, the entire country was covered. So free diagnosis and treatment are provided under the program. More than 20 million TB patients are treated under the RNTCP. More than 3.5 million additional lives have been saved. And then 1.4 million TB patients were tested for drug resistance. And again, 0.14 million, the figures will slightly change. It is a slightly relatively older slide. And million drug resistant TB patients are diagnosed, and more than 0.7 million TB patients are notified from the private sector. Right, you see, the MDG or the Millennium Development Goal that we have told, you see in India, the TB epidemic have started reversing. The incidence, it was falling about 1.2% per year. That is the rates That was what was in that year. It has come down. And then the prevalence, there is a 50% drop in the TB prevalence between these times. And then about a 50% drop in the TB mortality, right? And then again, but remember, there is a huge burden of deaths and suffering still remains in India. There is estimated 22 lakh incident TB cases in 2014 with the 2.2 lakh deaths. Even at that time, when our target was to have the MDG or the Millennium Development Goal. But remember, I have told you, now our target is the SDG or the Sustainable Development Goal. So again, as you can see, the incidence from 289 per 100,000 population, we have reached about 217. And then the mortality has come down from 56 about 36. So now what are the dimensions of the TB control? It has got three important dimensions. You see, TB is just not, you just make a diagnosis, if is positive, give them the treatment and that is not the end of the story. In any public health program, I think we have to take into account, obviously the clinical is an important issue, the diagnosis and treatment. But of course, there are many other two other important issues, that is the public health and the social issues. The public health issue is the patient support, engaging all the healthcare providers, and the prevention of the disease. And then the social responsibility is the community empowerment, multi-sectoral approach, addressing the non-health determinants of the TB treatment and the TB control. I think this is a package. It is just not the clinical issue. You see, if you see the what we have achieved in 2018, if you see the total TB cases notified about 21.5 lakhs. In 2019, it was 24 lakhs. And in 2020, it has come down to 18 lakhs. Please see that this is the time when we had got the COVID, and we'll also discuss that subsequently. Similarly, proportion of patients with known HIV testing. So large number of patients, they know their HIV status. Then 9%, then you see the universal DST, because each patient of TB should know about the drug resistance status, particularly the rifampicin resistance status. So again, I can see over the years it is increasing. The treatment success rate has increased from 66% to about 82%. And then the proportion of children less than 6 years initiated on, the preventive therapy, the isoniazid preventive therapy is again increasing about from 3% in 2018. In 2020, about 35% of the children, they are getting now prophylactic therapy. Again, there is an expansion of the microscopy centers to improve the access. The primary healthcare centers where a laboratory technician is available, and in the phase 2 there will be other PSC. So the current status is, you can see in 2017 we have got around 14.5 thousand cases of microscopy centers. In 2018 it is again went into about 17,000, and then by the end of 2019 we have got 20,000. So there is an increase in the availability of the microscopy center. That is about one microscopy center for 68,000 population of the country. Again, the molecular testings, the CB0 or the TrueNOT, in 2017 we have got only 1,135. Then in 2019 we have got about 1,530 cases of machines to do the rapid molecular testing. Similarly, the universal drug susceptibility testing, as I was telling you, all TB patients to be tested for rifampicin resistance. So the current status is 81% of the target we have achieved. And again, you can see over the years there is an increase about from 2017 in the 2018 it was another increase of 51%, and then the number has increased. The about 66,000 cases of DRTV was diagnosed in the year 2019. Similarly, the CB0 utilization, I have already told you, these are the number of tests per month done. Per month it is increasing, as you can see. So then again, another strategy that was put on, the name I have told you about the RNTCP. So now, because to give in a thrust and begin to move towards the NTB by 2025, Then the first January this year, the name was changed to National TB Elimination Program, or what we call as the NTEP. From RNTCP, the name is now National Tuberculosis Elimination Program, with this insignia that you have to have a TB Mukta Bharat, or what other Nara or other which is given in the TB Harega Desh Jitega. So this is what is the symbol and the emblem of the program now. However, now coming as I have already told you, the burden of TB, as you know, the global TB report, it still says the number of deaths. You can see there is a reduction, in 2000, in the year 2000, it was about the reduction in case of the HIV negative cases. There is a reduction from 1.7 million. We have come down to 1.2 million. And similarly, there is a additional 2 lakh deaths because of HIV people. So there is a reduction from the 6,78,000, 2,000. Now it is 2 lakhs. So there is again a significant reduction. But again, the point is, remember the milestone which I have shown you, but this is not fast enough to reach the 2020 milestone of a 35% reduction between 2015 and 2020, if you remember that. So the cumulative reduction between 2015 and 2019 was 14%, which is less than halfway towards the milestone. Remember, this is one issue. Then again, as for the new cases, again you see there was about 10 million cases. I said the decline is only 9% decline. It is again not the same. Similarly, number of deaths, there is only the decline is only 11%. Number of MDR TB cases, there is a huge number. So all these parameters are still far below the milestones needed for the Ntv strategy. So this is what is very important. What are the challenges? Why you are not able to reach that? Because of under-reporting and uncertain care of TB patients in the private sector. There is unregulated private sector or healthcare delivery system in the country as a whole. The reaching the unreached, marginalized and vulnerable population, people in the difficult areas, in the hilly areas, tribal population, drug-resistant TB, comorbidities like HIV, diabetes, undernutrition, overcrowding. So these are the factors which are responsible for TB. And there is a wide geographic variation in the epidemic. And of course, there are many more factors, as you can see. So let us see the latest report, that is the India TB report 2021 that was released March this year. As you can see how it works, we have got a Ministry of Health and Family Welfare. We have a central TB division, which is supported by national institutes. We have got 3-4 important national institutes of TB, that is NITRD, National Institute of TB and Respiratory Disease, or LRS Institute at New Delhi, where I have got the opportunity of working as its director. Then we have got the TRC, or now known as the NIRT at Chennai, and NTI at Bangalore. So these are the national institutes. Then we have got the state TB cells, the different states, then the district TB centers, then the tuberculosis units, then the TB testing centers, and the TB treatment center, what is the DOTS. And in the state TB tail, we have the state TB training and demonstration centers. And then at the district level, we have district hospitals, block, and the community health centers, then PSCs, and then health and wellness center. This is, this is how through this structure the program works. And again, you can see these are the scale of achievement in the notification over the last 5 years. You can see these are in the blue lines, these are the estimates. These number of cases should be there in India. Say, for example, in 2015, it was estimated that our number should be around 28.4 lakhs should be in the country. But we could, how much we could detect, we are not able to reach even those, these estimates. This red one that shows from the, these are the WHO notification. These are the total cases notified. And then the incident cases notified in India, both new and the relapse cases. So you can say we have even not yet reached that target. And in 2020, the problem was because of the COVID. You can see this one shown in red. You can see in comparison to every month wise, you can see month wise you are doing very well. January, February, and then somewhere in March when the COVID came in, you can see the case detection rate came down quite heavily. You can see that. And then this is the from the public and the private sector. The private sector, which was very minimal, about 21% of the cases. So that has gone up to 21, 25, and 28% of the cases. So the private sector is engaged, but again, because of COVID-19, in 2020, the overall figure dropped down both in the public as well as the private sector. So this is again most commonly seen in case of the males in comparison to females. And again, as you can see, the age-wise, you can see the 30 to 35 is the age which is the most productive age group. And if you add that to 15 to 45 is the most common age of TB cases in that year. Again, you can see the total TB notified in 2020 which is around 18 lakh cases, and the treatment about 95% of them treatment could be initiated under the program. Again, please note that still 5% of, even if we notified or we detected, but still 5% of the cases could not be initiated on treatment. You can see about 5% could not be both in the 3% in the private sector and 6% in the public sector. Then the 53% of them we could know an outcome, and then another 47% still they are on treatment, so their outcome could not be assessed. So what about this is the what is the treatment success rate? As you can see, in the year 2019, you see the case notification was around 23 lakhs. So the treatment success rate was 82% of cases, 4% of people died, and 4% lost to follow-up, 1% treatment failure, regimen change in 2%, and not evaluated 9%. So again, please note that the treatment success rate is 82%. Still, 18% of the cases, the treatment is still not successful. So this is again a huge number and a matter of concern for the program and also for the Ntv strategy. Then these are the what is the strategies for improving the case finding. Earlier once it was always the passive case finding. That means based on the footfall in the health facility, whoever is the symptomatic, he comes to the health facility. But again, then subsequently from 2001 onwards, we had intensified case finding, particularly in the vulnerable group like the comorbid conditions like HIV, diabetes. Then active case finding that started from 2017 onwards, where there was a systemic screening of vulnerable population like migrants, small slum population, prisons, contact of drug-resistant TB patients, pediatric patients, etc. And then there was a 2020 onwards, they have got a population-based screening like vulnerability mapping, periodic screening of the vulnerable group. So they are the targets. They are the additional targets, while all these other things are ongoing. So these are additional, strategies to improve the case finding. As you can see, this is at a Kangra disease where you can see this is the active case finding activist and different villages, how from house to house they are going with the truck drivers. Here it is the workers and so on and so forth. So this is the case finding. And again, these are the number of cases needed to screen. That means the size that shows each state, so many numbers are to screen to detect one case, right? So you can see states like Manipur, Lakshadweep, Gujarat, Odisha. So these are as the size of the bubble it shows, then the number of, so many number of cases. Say for example, on an average, about 10 cases are to be examined to get one case of TB. Similarly, this one is the various vulnerable groups, like say for example, slum, then the undernutrition, diabetes, etc. They are to be also screened. Now coming to the laboratory issues, as you say, we have started with the simple ordinary light microscope, then use the LED microscope, then the genetic testings like a gene export and a TrueNAT, and then the biosafety level 3 laboratory for culture and other issues. That is how, again, you can see these are the diagnostic network improved. As you can see, I have already told you the microscopy center. Actually, this is again I was telling you about 20,000. Now the exact figure, it is more than 21,000 microscopy centers now. Then the nucleic acid amplification machines is now more than 3,000. That includes both the gene export as well as the TrueNAT. Then culture and the drug, the DST laboratories is about 47 now in the country. Then the IRLs or the intermediate reference laboratories 34, and the national reference laboratories we have 6. So there is a huge expansion over the years about the laboratories. And again, these are the so many huge number of cases where the nucleic acid amplification test done, then the second line LPA. So all these tests are being done in a very rapid manner. So then if again I summarize the progress done in the last couple of years for the treatment of TB, there is a pan-country rollout of injection-free regimens, then the access to the free drugs to the private sector for drug sensitive as well as drug resistant TB. There is a decentralization of the molecular testing for drug resistant TB detection and subsequent linkage for treatment initiation at the district level. Then decentralization of drug resistant TB treatment facilities by establishing decentralized, we have got now to treating the drug resistant TB, we have got now 173 nodal DRTV centers and 620 district DRTV centers. These nodal DRTV centers by and large the medical colleges and other big chest hospitals. So you can see we have got now nearly 800 cases of centers where drug resistant TB is treated. Then again, more than 5 lakh treatment supporters for patient-centric treatment provision through community treatment centers. Earlier it was known as the DOT center. Now it is known as the community treatment center. Then aligning the national, programmatic management of drug resistant TB guideline with the WHO recommendation. That means the country is now following the WHO recommendation to treat drug resistant TB. Then universal drug susceptibility testing, or what we call the UDST, of all notified, all TB patients, as I was telling you. Then rolling out of the newer drugs like bedaquiline and delvanid for the treatment of MDR and XTR TB. Then implementing shorter courses for MDR and rifampicin resistant TB regimens with injectables, all oral longer regimens, and a newer drug containing regimen. So all these things are very quickly done. Then again, we know what are the determinants of TB. There are certain risk factors. So these are the 5 important risk factors that has been, identified. Most important is undernourishment, smoking, HIV, diabetes, alcohol, and other drug abusers. So these are the 5 important attributable risk factors for TB. And again, you can see the program is addressing the comorbidities, like HIV, diabetes, tobacco, and TB tobacco. This is what the joint venture. So then there is a constitution of TB comorbidity committees at the different levels. Again, you can see here the INS preventive therapy, then the early detection of TB among people living with HIV, prompt treatment of TB HIV, fixed dose combination, including test and treat policy, management of TB HIV. I mean, so many things I cannot go on because of a shortage of time. So, so there are many achievements. As you can see, there is a collaborative activity between both the programs. So now coming to diabetes, as you know, the TB and the diabetes, they affect each other. The type 2 diabetes has 3-fold increased risk of TB. And again, patients of TB has a 2-fold increased risk for developing diabetes. TB causes glucose intolerance. Diabetes may alter clinical presentation of TB. And also diabetes may increase time of sputum conversion. Similarly, there is a double risk of drug resistant TB in diabetics. And then the odds ratio for TB in diabetes, there is a chance of treatment failure about 9 times, relapse about 1.64 times, and death about 1.88 more in comparison to those who are non-diabetics. And due to lack of early detection and treatment, that leads to high cost and out-of-pocket expenditure when there is both TB and diabetes. So again, in 2020, 82% of all notified TB patients in the public and private sectors, they have been screened for blood sugar, and 8% were found to have diabetes. 8% of the TB, they have got diabetes. Then out of these, 54% comorbid patients were referred to NCD, or the non-communicable disease clinic, and linked to the anti-diabetic treatment. So therefore, there is a good coordination. But again, although these figures may look impressive, but you see, overall, not still 18% of the notified TB patients, they do not know about their diabetes status and so forth. So this is the figures of different states. Again, you can see the state-wise intensified TB case finding, as I was telling, 7 to 8%. That was this all India figure, and then the highest, the best performance is the Chandigarh, Goa, and Bihar, and then Odisha. It is about 2% only, and then many other states in the country. So these are the national level intensified TB case finding in the non-communicable disease clinics, particularly the diabetes. You can see the number of cases diagnosed is increasing, and then the patients screened for TB. Again, all those patients are not screened for TB. Remember, that is another point of worry. Same thing with the TB and the tobacco. So this is the TB tobacco data, where the both TB and the tobacco, or the TB patients have been using tobacco. So under this national TB elimination program, 69% of TB patients, the status is known for their tobacco usage, and out of this, 13% of TB patients were identified as tobacco users at enrollment, and among those screened, 27% were linked to tobacco cessation services, not everybody. Again, this is the TB and the nutrition. As you know, there is a strong correlation between TB and the nutrition. The risk of TB increases by about 14% for each unit reduction of BMI, and there is a risk of recurrence is 4 times compared to those with a normal weight, and only about 1/3 of men and 1/4 of women had normal range BMI after successful TB treatment. When we give the nutritional support to TB patients, there is improvement in the weight gain, muscle strength, and quality of life. There is a reduction in the mortality, and that provides a shorter time to sputum conversion and greater sustained microbiological cure, thereby decreasing the recurrence of TB disease. Again, it improves the adherence to therapy if you provide them nutrition. Again, so this is very in a different way. They are linked, as I was talking to you. That is what we call as the Antyodaya Anna Yojana of the Ministry of Food and Civil Supplies. Then Women and Child Development, Integrated Child Development Services. Then Food Security Act 2013, which is implemented in 11 states. And then TB specific schemes in certain states like Chhattisgarh, which provide supplemental nutrition often as dry ration. I think many, and then the National Nutrition Mission, what is known as the Poshan Abhiyan. So these are certain schemes which are also linked with this TB control program. So then again, to address the gender issues, you can see there is a specific focus on the women, then TB and pregnancy. As we know, both pregnancy and the postpartum period, there is also an increased risk. That is again another area where attention is being given. Again, India has an estimated 44,000 pregnant women with TB in 2011, and contributed to about 20.6% of the global burden of TB amongst pregnant women. So this is an important area. Similarly, you see in 2020, only 23% of the female TB patients screened for pregnancy, and 0.7% were pregnant. However, there is a large amount of data limitation. So is it, so we have not yet gone in full speed in screening for TB in pregnant women. And then about pediatric TB, this is an important cause of death among children less than 15 years of age. You know, globally, there are about 12 lakh children had TB in 2019, and 1.9% of these died, including those having HIV. The estimation for India was about 3,42,000 incident or new cases every year. And this is about 31% of the global burden, and 13% of the total TB in India is due to, you know, pediatric TB. And it is estimated to be 10% of the total TB burden of India. However, the actual report is around 1,02,000 cases. And that is coming around 5.6%, which is expected it should be about 10 to 13%. So there is almost 50% of the missing cases in case of children. So there are 27 crore children between the age 0 to 18 years as per the census 2018, and 25.3 crore adolescents in the age group 10 to 19 years. So almost 3.42 lakh children develop TB every year as per I have told you. So we are missing about 50% of the cases. So this is the state-wise percentage of pediatric TB cases out of all cases notified. As you see, for the country as a whole, it is about 8%. In Odisha, the report is around 4%. So not all pediatric TB cases, even in our state, are not notified. So they have drug-resistant TB in children. That is again a very difficult area. And then we have got not much information. So there is no official data. In 2015, about 5,586 DRTB cases out of the 12 lakh TB cases were reported. And then it is reported that by 2022, the number will be increasing to 1,15,000. So again, much attention is being given for DRTB cases in pediatrics population. We have got DRTB committee, child-friendly formulation, and then clinical experience is limited in using these drugs. And then what is the outcome, we do not exactly know, but I think a lot of activity is still going on. Again, to give a impetus to this, that we have got centers of excellence, what we call PCOE or Pediatric Centers of Excellence. There are 5 zones. For East Zone, for Odisha, the Pediatric Center of Excellence is the IPGMR, or that is the Institute of Postgraduate Medical Education and Research, Kolkata in West Bengal. So our state is in that, that will be our center. So then I think another important area which is developed by the program is the National Strategic Plan 2017-25. So again, here the vision is a TB-free India with a goal of universal access to quality TB diagnosis and treatment for all TB patients in the community, and with the objective of early diagnosis, access to high quality treatment, scaling up access to effective drug-resistant TB treatment, decreasing the morbidity and mortality in HIV TB, and extending the RNTCP services. And now, of course, it is NTP to the patient in the private sector even. So this is how from 1.5 million to we have to go to care for 3.5 million, which will accelerate our journey towards a TB-free India. Again, as you can see, there is a huge gap in the TB detection and the targets. As I have already told you, these are the targets for different years. But you can see the case detection is quite low. And then our approach should be detect, finding the TB cases with an emphasis on reaching every TB patient in the private sector, and then treat a TB case with the high quality anti-TB drugs, and then prevent the emergence of TB in susceptible populations and stop catastrophic expenditure due to TB by all. Then build and strengthen the supporting system, including enabling policies, empowering institutions and human resources with the enhanced capacities. Again, we have to detect, the private sector has to come up in a great way. They are coming up, and then engaging with the private sector is the key. And then the reaching to TB patients in the private sector, we have different ways and different tactics. Incentives were given to private provider for rupees 1,000. For patients, it is 500 per month. For tribal patients, it about 750 rupees. So there will be, the notification is mandatory, both the laboratory as well as the clinics, hospitals, chemists, public health action by health staff, by counseling, home visit, treatment adherence, HIV DMS training. Then these are the some of the acts of omission and commission. And then intensified case finding, we have already talked about that. And then the diagnostic expansion with those group of people. We have to treat by expanding the treatment service and addressing the priority population, that is the drug-resistant TB and the TB HIV. And then the patient support system should be there in place. Then treating, you see, we have got the many achievements have been achieved by the program, like treatment for the so-called drugs sensitive or drug susceptible case, let me put it that way. We have a daily regimen with the DST guided treatment is also there. Based on that, first we isolate if is rifampicin resistance, if is INH resistance or not. They have a certain regimens and there are newer drugs. Then the patient-centric care is, there is a IT-enabled adherence support, then a single window delivery of care, active drug safety monitoring, and decentralization of services. So these are what should be the patient-centric care. And then reducing the out-of-pocket expenditure, like giving them financial incentives, and what is all also through direct benefit transfers. So this is this put-on transport has to be done through the India Post. This is the universal DST, strengthening the sample transport and expansion in the private sector. Then the certain regimens, as I told you, it has been newer drugs for drugs like bedaquiline, drugs like delvenamide, drugs like ritonamide, etc. So these are very, very important also. So then the directly observed treatment, and then the ICS based, I think this one I'll skip. So now this is a very innovative way of information technology. Here you can see. So once the patient takes out the once the patient takes out, you can see there will be number will be coming out. You can see it takes out, and then the number can be, it is a toll-free number. That means the patient, it shows that the patient has taken the pill. So then again, the direct benefit transfer schemes, there is to reduce the direct and indirect cost to the patients. So honorarium is given to the treatment supporters also for provision of treatment to the TB patients, for adherence, adverse drug reaction monitoring, counseling. It is 1,000 to 5,000 rupees. Patient support to tribal TB patients in the form of rupees 750 per month. And then new schemes like nutritional support to a TB patients. The patient gets 500 rupees per month, and incentives to the private provider, that is 500 for notification and 500 for follow-up with the treatment outcome of another 500 rupees. So this is how the direct benefit transfer is given. So the strategy is to build the urban TB control, health system strengthening, advocacy, communication, and social mobilization, and then surveillance and monitoring. Then this is through the NICHA or the IT technology is done. Then again, we have got the various forums at the state TV level, state level, at the district level. Then the financing, we have got a domestic funding. It has been more than tripled between 2016 and 18. Resource increased in commensurate with the national strategic plan, that is $1.7 billion over 3 years, and then $82 million for nutrition assistance to TB patients. So these are some of the things that are being done. Again, I told you there is a use of digital technology by using which uses to give direct benefit transfer, patient tracking, provider engagement, digital transmission of results, logistic management, drug surveillance, etc. And then national TB call centers to give them. And for prevention, we have airborne infection control measures, strengthen contact investigation, prevent treatment, manage latent TB infection, and address the determinants of disease. So you can see with a population of 1.35 billion, we have got 36 states and union territories, 712 district units, more than 3,000 TB units, 6,000 blocks, and designated microscopy centers. So these are all being done. So these are the, that I have already told you, the various diagnostic centers, treatment supporters, CBNAT machines, DRTV centers, etc. So the way forward for Ntv strategy is we have got the diagnostic algorithm, intensified TB case finding, regimens, enhanced adherence support, treatment monitoring, single window delivery for TB HIV, then for DRTV scaling up, new surveillance, extend care to the patients in the private sector. So this is what the thrust area for the private sector. And then obviously the vicious cycle of TB, poverty, malnutrition, this forms a vicious cycle. The TB causes poverty, poverty leads to malnutrition, malnutrition comes TB. So this is the vicious cycle. So we have to redefine the multi-sectoral approach, health, Department of Mines and Industry, food and civil supplies, and many tribal welfare. So these are the various issues, housing, health, many things come into picture for a holistic approach for the Ntv strategy. So these are the active TB case finding strategies. Now the Delhi regimen rollout has been done across the country, and you can see the drugs will be taken daily. The dose of drugs are according to the body weight. There is a FDC, or the fixed drug combination tablets, will reduce the pill burden. Child-friendly formulations are dispersible tablets. Information technology, as I told you, for the adherence support system, and regimen is acceptable to all healthcare providers. Earlier when we had got intermittent regimen, there was objection. So now it is a daily regimen. And again, we know this is the upscale of the CBNAT. I am already telling you how it has been, upscaled. And then the National Urban Health Mission is also now part of the RNTCP. And these are the universal health coverage for social protection to take care of the cost of treatment, cost of travel, nutrition, wage loss, out-of-pocket expension. So that is also being taken care of. And there are various patient support systems, what we call as the Jan Trinity, that is the Jan Dhan Yojana, Aadhaar, and the Nikhya, that is what is the Jan scheme. That is being again done. This is the patient treatment in the private sector. In the private sector is still a big problem. You see the Uttar Pradesh having the private people go to the private sector, then in the other states, there are the different areas, because that is also an important healthcare provider. But the problem is they should, and fortunately they are coming up to adhere to the program guidelines and to cooperate with the program. Even now it is as you know, TB is a notifiable disease. You have to notify TB. So these are the various intensified, various clinical settings, social settings, and geographical areas where the intensified TB case finding has been taken up. And again, you can see accelerating access to the diagnosis of pediatric cases. As you can see, it is done at the various centers in the country. And then coming to the MDR TB, I'll just see 4 or 5 more slides. You can see around 5 lakh MDR TB cases, I told you, in the world. So, but only the problem is only 1 in 4 MDR TB cases are diagnosed. That is also issue in this country. So, and again, out of that, only not everybody could be put on treatment. So only 1 in 9 MDR TB case is successfully treated. That was situation before 2020. So here, so therefore, each dollar invested in TB will yield about $85 in return. Again, you can see these are the missing cases. So you can see, as we have told you, about 1,350 new drug-resistant TB cases in a day in the world today. That is what is the situation. And this slide I have already shown you. In India, we have got about 1.24 lakhs cases of MDR TB cases. And again, 27% of all MDR TB cases in the world are in India. That follows China, Russia, Pakistan and other countries. Again, you see there is a huge gap. India has 27%, China has got only 14%, and Russia is having only 8% of the MDR-TB cases of the world. Again, you can see we have got periodic drug resistance surveys in the country, starting from 2000 till recently 2016. You see the percentage of MDR-TB in new TB cases, it is increasing, and you can see at present, we have got about 2.84% cases of all new TB cases are having MDR-TB, and around 11.6% of previously treated TB cases are having MDR-TB. Again, remember, this is a huge figure. So this is and fortunately, because of the National Drug Resistance Survey, we know the DST pattern of 13 different drugs in the country, what are the percentage, etc. I have already told you. So WHO has got guideline development from 1996 till about 2020. In every year or every 2 to 3 years, they provide guidelines. So then again, see in what initially it was known as the Programmatic Management of Drug Resistant TB in India, or what we call as PMDT, that started in 2007. It was the DRTV services were initiated, where we are giving focus on the solid culture and the DST in specific laboratories, and the testing was limited only of patients with unfavorable outcome, and there was a standardized treatment only for MDR-TB, only that I'll show you subsequently. And then I think with the National Strategic Plan 2012-17, our strategy plan for the focus changed, and there was introduction of new, the molecular diagnostics. There was a nationwide coverage of urban development, universal DST, the introduction of Delamanide, Sutter, longer oral MDR-TB regimens, then the expansion of CBNAT, and again other things they came in. So there is a drastic change between 2007 to 2021. Again, I was telling you, we had a standardized treatment regimen. So with 6 drugs for 6 to 9 months, and another 4 drugs for another 18 months. So total 24 to 27 months was treatment was given for MDR-TB till about 2017 or so. So then we had the same thing, and for XTR-TB, we had got again, it's a very toxic and very large number of drugs were given for similar period of 24 to 27 months. That included an injectable drug for 6 months or so. And again, the result was around 61%. So fortunately, I was the one associated with this MDR-TB clinical trial in LRS Institute in 2006, and this we published in 2009, and at that time the success rate was around 61%. But again, you see, when it went into the programmatic condition, you see till about 2017 with that longer regimen with injections for 6 months, you see the success rate has always been less than 50%, and the death about 20% on an average people died. And then this one that will show about again 20% of the patient then run away. We don't have got any information. We could not follow them up, right? The success rate was not very, very encouraging. Again, for the XTR-TB, the situation was still worse. The result was again less than 30% on an average, and most of the patients again died. About 40% of the patients were dying. This is again, that was what happening in 2017. And then in comparison to the global report and then the Southeast Asia, other countries were slightly inferior, but by and large, what I'm trying to tell you, the success rate for treatment of MDR, XTR with the existing regimens at that time was not very encouraging. So then came the issue of newer drugs. Again, another tragedy for TB in the history of TB is that, the first drug was discovered in 1943, that was streptomycin. Then over the years, many other drugs came in, PAS came in 48, then the INH in 1952, and so on and so forth. But again, you can see the dot stopped there. the dot stopped once the rifampicin was in 1963. Then starting from 1963 till about 2010, 2012, how many years you count? It is almost how many years? It is 37 and 12. So nearly 50 years, there was no new drug in the TB. You see, and this is the time when anti-cancer drugs, anti-cardiac drugs, so many drugs, there was a rapid exponential increment, but nothing happened in the field of tuberculosis. But after 2010, when the TB Alliance and the TBDA, they are all formed, and then the new drugs came in 2012, and then everything changed. And now in 2021, there are many new drugs. I'm not trying to tell you. I think the regulatory market approval is 3 drugs: bedaquiline, delamanide, and pretromanide. These are the 3 drugs which have come to the market. Then many more drugs and many more regimens, they are on trial. So I'm not going to tell you about that. So there was a key change. There was an interim policy guideline 2013, new recommendations came in. And then in 2020, we have got consolidated guideline on DRTV that was came on, and then everything changed. And there were 5 priority actions to address the global MDR-TB crisis. And that is what India also followed to prevent the development of drug resistance through high quality treatment of drug susceptible TB. If you don't handle the drug susceptible TB, you mishandle them, then that will develop into drug resistance. Then expanding the rapid testing and detection of drug-resistant TB, provide immediate access to effective treatment and proper care, prevent transmission through infection control, and increase political commitment with financing. So these are the 5 important key actions, and fortunately, India TB control program followed that. WHO developed the consolidated guideline, so that I told they classified the drugs according to their effectiveness. Then now the drugs are grouped into group A, B, C, and these are based on their effectiveness and then the toxicity. So the best drug will be 3 fluoroquinolones like Levo or Moxi, bedaquiline and linezolid. Group B drug will be clofazimine, cyclosporine, and the other drugs comes in the group C. So that is how the drugs are grouped now. And then this is again the same slide I have shown at the different years and what are the various achievements or what are the various focus. And the Ntv strategy, again, you can see this one on the important component, that is to treating all people with TB, including drug-resistant TB and patient support. And then, so now there is a new definition for those who are listening. The XTR-TB, the pre-XTR-TB, it is the TB caused by M. tuberculosis strain that fulfill the definition of MDR or rifampicin resistant TB, and that are also resistant to any fluoroquinolone. Remember, the injectable thing has been removed because, as you will see in the subsequent slides, there is no more injectable recommended for treating MDR TB or even the drug susceptible TB. They are taken off. So now it is only fluoroquinolone. Similarly, XTR TB caused by MTB and which fulfills the definition of MDR. That means it is essentially a MDR or a rifampicin resistant TB, but in addition, it is resistant to any fluoroquinolone, and in addition, at least one additional group A drug. What is a group A drug? I have already told you. It is bedaquiline and linezolid in addition to Moxi or Levo. So fluoroquinolone plus resistance to either bedaquiline or linezolid, right? So that is how the definition is XTR-TB, because here the injectables have been taken out. So again, India also has developed the guidelines. So this is a summary of what is the status of DRTV services over the years. As you can see, the number of people being tested for DRTB, and these are the number of cases we have detected, and these are the number of cases we have put on treatment. But again, although the number is increasing, again you see by 2019, it was 66,255 cases could be diagnosed with MDR-TB. But if you remember the slide which I had shown you, what was our expected value? At that time, it was something like 1.24 lakhs of cases of. So that means only we could detect 66,000. That means another roughly it is only 45% of the cases of MDR TB in the country. We are not able to diagnose. Again, out of this, we could only put still 10,000 cases. We could not put them on treatment. That is again another disadvantage, right? So far the cumulative performance since its rollout in 2007 or 2012-13, I should say, we have got 352,000 cases of MDR TB diagnosed, and out of that 308,000 are put on treatment. Still about 45,000 are not put on treatment. XDR TB around 15,000. Then INH resistant TB around 38,000 diagnosed. And these are the people who are put on Sutter MDR TB regimen, about 96,000. Bedaquiline containing regimen about 23,000, and a Delamanid containing around 600 cases. So here you can see these are the various, I have already shown you gene expert machines, TrueNAT machines, and then we have got the DRTB treatment centers that I have already told you. So the problem of drug resistant TB is it is underdiagnosed, missing TB cases, limited testing, linkage and capacity. The treatment was longer duration, less efficacious, I told you, and the complexity of the management, treatment, side effects, cost, then complexity, adherence issue, adverse drug reaction, and severity of disease. And then this is although please don't look into this complex slide, it looks complex, but this is a diagnostic algorithm for a DRTB patient, drug resistant TB patient, and how one should go. Again, similarly, the INH resistance cases, if there is INH resistance, the outcome is very poor. There is a failure rate about 49% with success rate 31%, and 40% of them will progress to rifampicin resistance or MDR TB. So therefore, INH mono resistance is a special focus. And then newer drugs, I have already told you, after almost 5 decades, these 3 drugs I have already shown you, and fortunately we are using drug. So now we have a standard DRTB regimen under our program. So now it is 3, it is all oral INH mono or polydrug resistance, the treatment for INH resistant TB, then Sutter MDR TB regimen, and all oral longer MDR TB regimen. So what is the all oral INH resistance? So we give 6 months rifampicin, INH, ethambutol, and levofloxacin. Not recommended to add injection streptomycin or other injectable agents. Then secondly, till May 2020, nearly 22,000 patients have received. Now coming to the Sutter MDR TB regimen. So this is the experience so-called Bangladesh regimen. But the only problem here was there was an injectable for kanamycin. But you see, the relapse-free cure rate was about 88% of cases. Here the duration was 9 months. You see, earlier the standardized one I have told you about 24 to 27 months. Now this one came down to 9 months. So here the treatment outcome success rate was about 81%. The same thing even in Africa, in 9 different countries in Africa. Again, you can see very good result. And this Sutter regimen has impacted that from about less than 50% with the standard regimen. Now it has gone up to 82% of cases. So now what is the Sutter MDR TB regimen? It now contains, it is 9 to 11 months, Moxi, hydrose Moxi, pyrazinamide, ethambutol, clofazimine, injectable kanamycin, ethionamide, and INH. And then in the continuation phase, we take off, injectables, and then the other drugs like moxifloxacin, pyrazinamide, ethambutol, clofazimine, and these 3 drugs are taken up. So this is what, but the only problem here was that there was an injectable. So you see what was the effectiveness. Again, you can see in the program, which is a very large number of patients, nearly 10,000 patients, 11,000 patients. You can see 68% was the success rate, right? And again, you can see how from with the Sutter MDR TB regimen, it is now around, this is the quarter, third quarter, second quarter, and then subsequently the results are improving to around 68, 65, 68% of cases. So now there is a possible change, not possible. This is the proposed, no more proposed. It is now a policy. Now we are replacing the kanamycin. It is a bedaquiline containing regimen. Total duration is 9 to 11 months, and you give 4 to 6 months of, the drugs like bedaquiline for 6 months, then levo, clofa, pyrazinamide, ethambutol, high dose INH, ethionamide. So these are given for 4 to 6 months, and then after that, levofloxacin, clofazimine, pyrazinamide, ethambutol. As I have told you earlier, bedaquiline is given not more than 6 months. So this is what is the all oral Sutter regimen, and then it is to be given to whom to give and whom not to give. Now all oral longer MDR regimen is again, these are the grouping of drugs. You use all 3 group A drugs, and if possible, at least one or both medicines, and then some drugs from the group 3. So this is how you prepare a MDR regimen. So these are the drugs which is given for 18 to 20 months that contains bedaquiline, levofloxacin, linezolid, clofazimine and cycloserine, and bedaquiline is stopped after 6 months, and these other 4 drugs are continued for a period of 18 to 20 months. So you see, these are what are the latest recommendations. And again, you can see the success rate is about 83% of cases. This is the conditional access program result. So it is, so now we are moving towards the injection-free treatment for the INH, I told you, and for the Sutter and a longer MDR regimen, I have told you. Then another thing which is coming recently is the BPAL regimen. This contains bedaquiline, pritomanid, and linezolid. This is not yet recommended, but the country is going on for a trial to see how it is doing with our population. So the trial is going to be started very shortly by the program, as well as the TB consortium of the ICMR. The ICMR will try it in the MDR TB cases. So I think there is a, the GenX trial is only a dose reduction for linezolid. Instead of 1200, we are giving 600 milligram, but the result will be the same. This is a trial already has come. So the country will go ahead with the 600 milligram dosage. So ladies and gentlemen, you can see this one, the so far what we have done. This was the regimen for the MDR and XTR. These were the success rates I had told you earlier, but now with the newer drugs, you can see the success rate has gone up to, with the Sutter regimen, it is around 60%, and for INH resistant cases, the result has gone about 78%. And then this is the this one about the Sutter regimen, which is again coming about 71%. Right? So this is the same thing I have summarized you here. So, and then so far, these are the number of cases on the left side. So different regimens have been used. So the national strategic plan is to prevent, detect, treat, and build a power. As we know, there are various causes of development of drug-resistant TB. The point is, when you are thinking of, when you are going towards Ntv strategy, whether all these causes are being taken care of. There is a genetic mutation, then the drug, when there is inadequate supply, non-availability of the certain drug, stock out or delivery disruption, poor quality, poor storage, wrong dosage. So these are the important lessons for the program, and those are treating with TB. Unless and until we remove these things, we cannot end TB. Then provider issues, unsupervised treatment. I do not know, many of you who know how the DARTS program is going on, you know, absence of guidelines, non-compliance with the guidelines, inadequate training of health staff, no monitoring of treatment, poorly organized or funded TB control programs, and inadequate drug treatment, that is unobserved treatment, poor adherence, lack of information, non-availability of free drugs, adverse drug reactions, social and economic barriers, malabsorption, substance abuse disorder. So these are certain issues which are also to be tackled. Again, as I have told you, we have achieved a lot, but the question is, are these achievements enough to go for a we have told you these are the strategies which I have already discussed. And then obviously the prevention we have to do for the INH prevention. Again, I told you preventive therapy is only 35% of the eligible patients. Similarly, for prevention of Drtv, we don't have a definite drug, but levofloxacin is now recommended as a preventive therapy for Drtv. Now as I told you, it is now a notifiable disease. Every college should have an anti-ART center and a facility for management of MDR-TB at the time of 4th renewal for admission of 5th batch of MBBS students. This is the MCI. Now it is, of course, the commission of the National Medical Council, I think, NMC. So this is what is the notification. So it is very important. So now let us see. I think I will just take 2 more slides, Dr. Patnaik. Let us look at a reality check. So what are we doing? So far what I told, what should be done or what is being done. The point is, are they enough to reach our Ntv strategy? Let us see. Have we got a recent authentic incidence or prevalence? Then the risk factors we all know. India was the diabetes capital, over so many cases in 2017. So it is estimated that by 2030 we'll have 92 million diabetics. And I have already told you how the diabetics and TB, they are interrelated. And again, 2.1 million, they live with HIV. Immunosuppressive diseases and the drugs used in this country is enormous. Steroid use, the many other immunosuppression drugs, the cancers, huge burden, this is immunosuppressive state. Organ transplantation is picking up in the country with immunosuppressive drugs, liver transplants, chronic renal failure, the many huge number of cases of chronic renal failure, bone marrow transplantation, leukemia. So these are all the risk factors that has to be taken into account, and those people are to be taken into confidence. Malnutrition, 20% of the population of the children are wasted, and 6% are severely wasted children. Low BMI is present in nearly 1 in 5 Indian adults. Occupation, 10 millions are at risk for silicosis. Silicosis is one of the important risk factors. Overcrowding, slums, prisoners, shelter homes. We have got 134 central jails, and the prisoners, so many prisoners, and the occupancy rate in the prisoner in India is more than 140%. They are overcrowded. Urban Indians living in slums, about 20%, about 100 million people, they live in slums. Over 9 million, that is 60% of the population of Mumbai, and 80.7% of Delhi, and 10% Bengaluru, 5% Calcutta, and 15% Hyderabad population, they are in the slums. Healthcare workers, such a huge healthcare workers. So these are the important risky group who need to be, taken care of. So we have got a huge burden. Again, coming to the LTBI or the latent TB infection. As I have told you in the beginning, 1/3 of world population, India around 40% of the population, adult population, if you take overall, so that is comes around 50 crores. Health is in the concurrent list. Center and state coordination is very, very essential. And every day you see the TV, how the center and state are coordinated. I need not have to spell you to, otherwise, I may be held up. Then it is delivered through the state health services. Then the finance ratio is 60-40. Many of you know or do not know. I do not know. Then contribution and management through the state, National Rural Health Mission. The process goes through the bureaucracy. Then the human resource, that is also very, very essential. Again, you see, we had the nationwide survey way back in 1955-58. After that, we do not have any national survey. The estimated prevalence survey in different areas, you see at the various places, but that is in sketch wise. So you do not, what I'm trying to say, we do not have a national data even as for, that is what is my take. Of course, now both the ICMR, the program and WHO, there is a national, prevalence survey is going on. So we'll get the result very soon. So what those surveys so far says, prevalence of bacteriologically public survey varies between 170 to 528 per 100,000 population. Prevalence of smear positive again varies from 108 to 428. This wide variation in prevalence indicates there is a diversity in TB burden in different parts of the country. So our strategy should change accordingly. Though the lowest prevalent rates are obtained in sites with the highest all TB notification rates, there is no clear correlation. So these differences in prevalence may be attributed to a mix of efficiency of TB control interventions. So I think the program managers should take note of that, living conditions and local cultural factors. Again, you see the tribal population, take for example, such a huge number, it is 703. And I think one of the reports shows it is as high as 1400 plus per 100,000 tribal population. So this is again a huge issue. So this is then you see the poverty. As the poverty goes, then this is the prevalence, TB prevalence rises, the richest and the poorest you can see. And again, what poor condition in this country, how many people have come up, that So the end poverty in all its forms everywhere. I do not know how it is to be done. There should be a design and a management models will be required. So there is a, so again, the health delivery system in the country, it is very peculiar. We have got public health sector where we have got primary health care, hospitals, health insurance schemes and other agencies there, and then we have got also in the private sector, we have got private hospitals, polyclinics, nursing homes, dispensaries, general practitioners and clinics, how much they are involved into the program. Then again, another interesting thing, we have got indigenous system of medicine, Ayurveda and Siddha, Unani and TB, homeopathy, then unregistered practitioners, then voluntary health agencies, and a national health. So these are the ways. So there is a varying health delivery system. And I think that has to be integrated into the TB control program. And again, you see how the TB management practice, it is not very long back. In 2010, you see, the practicing practitioners had never been approached or oriented by the local TB program. Only 6 of the 106 respondents wrote a prescription with a correct drug regimen. 106 doctors prescribed 63 different drug regimens. There was a tendency to overtreat with more drugs. So then you see private medical doctors at Dharavi, there was 100 practitioners prescribed 80, that was in 91. Then after about, 20 years, you see the things have changed. You see here, out of 81 different regimens, this is 63 regimens, only 17 regimens have come down. This is what is the progress with our, so I think we have to change, orient our, somehow, I do not know what way we have to orient. Then the functioning of the CTD or TB cells in the state, I am sure, is the manpower adequate? What about the field staff, the contractual manpower, the fighting everywhere, procurement issues, drug chain management, administrative issues, pharmacies, by and large, sincere effort is being made, has brought out significant improvement and achievement, but they are not yet fully. You see, this is the annualized rate. I'll just not go into that, but I like to show you one thing. These are the missing TB cases in different setups. So if out of the 100 cases, 67% reach diagnostic centers. And then out of that, 59 will be diagnosed with TB. And 53 will be registered for treatment. 45 will complete treatment. And the recurrence-free survival was 39. So this is a survey, what is happening actually in the field. This is again, I'll just skip and about the funding. I think I'll just like to show these 2 slides. NTP has increased by 4-fold funding between 2017 to 2020. The corpus of the NSP budget divided for existing intervention. So fund share, again, as I was telling you, fund share between the center and state government is 60-40, except for the northeastern and hilly states and UTs. The NSP has had substantial implication for state level planning and budgeting. So these 60-40, we don't talk at all. You know, the state has to spend something. So are they doing that? You see this horrifying slide. You see, this is 6 states are being shown here. You see, this is the financial management report. You see, this is showed the total budget here in the that is shown in a, I think you'll see it in a, which color is it? It is black color here, I could see. So here you can see the Bihar is only utilizing 19% of the budget. Gujarat, 95% of the budget. Then Madhya Pradesh, 35%. Maharashtra, 54%. Rajasthan, 32%. Uttar Pradesh, 52%. You can see even the budget, provided budget, provision budget is not being fully utilized in these states. So that is again an issue, ladies and gentlemen. So there is a serious challenge about financial challenge. So state governments face some key challenges as per the JMM report 2019. Then prioritizing TB and allocating funds in proportion to the TB burden, as well as channeling funds, then matching the resource commitment by center in line with the national strategic plan, low observed TB capacity, as you can see, there is a huge human resource shortage. There are non-HR reasons, timely dispersal or release of allocated funds. Again, you can see the fund allocation and expenditure. Again, I think I should not show you because Odisha is also here. So I'll not talk about that. So, ladies and gentlemen, there is a many issues. The prevalence surveys, research in TB is very poor. Vaccine trial, of course, there is no vaccine. We are doing one vaccine trial. New drugs, true political will, sufficient budget, human research, finance flow, center-state coordination, other administrative issues, reaching the unreached. We need newer thrust, and our medical education policy need to be turned. New drugs, as I told you, new drugs and new regimens. So the teaching TB in the curriculum is also very, very important. So another issue came in the pandemic came. You see, 60% case detection was only in 2020 because all the diagnostic facilities, all the manpower were diverted for COVID. That is rightly so. But what happened? The TB control activities came down drastically. They came down. You see, both human resources, diagnosis, treatment. You see, all these things came up. You see what happened? The case detection rate came down drastically. You see, in 2020, this is 60 case detection was only 60% of the expected. I was telling you the 18 lakh case detection only. So, and this, the very horrifying projection has been given by Stop TB Partnership on March 2021 that includes India. That says because of this COVID-19 pandemic has, put the TB control activities by the level of 2012, 2013. We are 8 years back, 10 years back to what was we are doing in 2012 and 13. So therefore, ladies and gentlemen, my take will be, what will be my take? It seems to be a difficult task. We may have to, change or redate the Ntv strategy. There is a hard task ahead. It is achievable, but coordinated effort and hard work. Good public health response is required rather than this. And the science does not fail us. We are responsible to fail ourselves. Jai Hind, and thank you for everyone for your kind attention. But sure, I am sure, TB harega, desh jitega, and with the cooperation of all of you. But I am sorry, ladies and gentlemen, I took a little, I exceeded my time, but I thought since it is a mixed audience, I'll try to give a overview of what is happening in the field of TB in our country. So thank you very much. And again, I apologize for my overshooting my time and taking a lot of time. Thank you.
Thank you, sir. Thank you, sir, for your very illustrative lecture. I think from the beginning start, we learn a lot of things. And to end also, we conclude that it is very difficult in the task for us. So I think we'll end or any questions we have got.
Thank you, sir. Thank you very much, sir, for your very informative and interesting presentation today. You very precisely and clearly explained all the programs of National TB program. So now I would request if anybody has any queries to sir, please. Or
I could
explain everything.
I'll be. I think there are certain questions, but I think I could see some in the chat box, but maybe I'll. I do not know if somebody can read them out for me.
I think Patnaik
But
said
the
that-
NTB includes extra pulmonary TB and sputum negative TB.
Oh yes, yes.
Every TB. And our
Yeah.
target is less than 10 per 1 lakh, all TB, including both pulmonary and extra pulmonary. Then mask use during COVID era can help NTV strategy. It is a very difficult question and thing. In the COVID era also already we have a case detection has decreased. Sir has shown that the case detection rate in COVID also is decreased, so much decreased that to compare, we have also gone back to another 5 years. As far the case, according we have gone back to 5 years. And one thing is that definitely mask will help in prevent the infection, infection. So
But the only question is, people are not using mask for COVID. So anyway, those who are using, I'm sure they should continue to use mask. And yes, it is a very, because of the because of the time, I could not discuss all these things. But yes, these are the positive contributors also for TB control. The use of mask, the social distancing, etc. So, people confined to their home. So all these factors are there. But question is, yes, these are the positive points, but provided we maintain it. You see, COVID may go away someday, but TB is not going away so soon. So we have to continue to use those masks for all those time when TB is there.
So there is a question from Dr. Nanda. The important constraint in RNTC was maintenance of quality TB services, which was shortage of staff due to rapid expansion phases. What strategy has been adopted to address this issue under NTP?
Yes, you very rightly, I think I have also shown you that the human resource and some of the non-technical, I think that is how everywhere you see the human resource crunch is very much. Even if the staff sanctioned for whether the staff is adequate or not adequate, is it? Hello?
Yes, sir. Carry on.
Yes, that's what I'm trying to say, and that is what I think I tried to convey the message. All the authorities, whether it is at the state level or the central level, you see, they should try to fill up those post and human resource. You see, I told you even the financial utilization is so, it is below 50% on an average. We are not able to utilize that fund. States do not contribute, and then everything, many states, as I showed you, some states, how the human resources are also not being, the sanction posts are also not filled up. Very rapid turnover. All these things happen. Then the training. You are very right. I think that should be done, and the program should go ahead with that. And that is each meeting, everywhere it is being emphasized. But it is those program managers who are there. So they should take the lead. At the state, it is the STO. And at the central level, it is the DTG-TV. And of course, all others. So they are the leaders and they should lead it.
Sir, another question is, MERM device not yet introduced in Odisha, will it be benefit the people in the community?
Which device?
RT-MERM, RT-MERM. I don't understand what is that. RT-MERM.
What is RT-MRM?
MERM.
Any idea, Prashant? I don't know what is RT-MRM.
No
What
idea.
is the?
Sir, I do not have it.
Next
What is
question,
the RT-MRM? What is that? I don't know what is that exactly.
Sir, another question from Dr. Manoran Behra. He is associate professor in medicine. How TB will increase risk of diabetes mellitus?
How?
TB will increase the risk of diabetes mellitus.
Yes, it is it interferes, as I told you, as I showed you, it interferes with the glucose metabolism.
Sure.
It is I think it is a well-known fact.
And another is the stress factor. Because of TB
Yes,
itself
yes.
is a stress factor.
Yes.
I think these are all questions. I think we end the
So,
questions.
yes, sir. So thank you very much, sir. Thank you, from Chatrasri, Professor Digambar Behra, sir, and our Professor of Pulmonary Medicine, Mar Patnaik, sir, and his team, and all the faculties to have spent such a long time with us today, almost 2 hours. So I thank you all.
Thank you, madam.
Yeah. Thank you, sir.
Thank you, sir. Once again, thank you, sir.
Namaskar.